Henry is not only former neurosurgeon, author, but a huge public figure and commentator, talking about the NHS, about how we live and die well, surgery, and also Ukraine is another of his great passions. For over 30 years, he has been going backwards and forwards to work on a charitable basis operating in Ukraine, and we may touch on that as well. But I thought, first of all, Henry, would you mind just telling the audience a little bit of background about yourself in your own words?
Well, I think the important thing is I went into medicine late, as did you, of course. I came from an Oxford academic family. My father was a legal professor in Oxford, and my mother was a German refugee, not Jewish, but a political dissident who had to leave Germany because the Gestapo, in effect, were after her. So I like surprising people because I'm so English and I have this typical Oxford English accent. When I say my uncle flew a Messerschmitt 109 in the war and my aunt was killed by the English. But it was automatic. I went to Oxford University myself and read personal protective equipment, what was once known as politics, philosophy, and economics. And I had what in those days was called a sort of nervous breakdown. I'd already taken a double gap year when I left school, and spent a year doing VSO in a remote corner of West Africa. And basically I fell unhappily in love. I'm not the first young man who fell unhappily in love. I mean, in retrospect, it was pathetic. But it was a sort of, as a German called a Bildung experience. And I ran away from Oxford and spent 6 months working in a hospital in the northeast of England, because it was partly fashionable at the time to have a middle-class guild complex. I was aware of the fact that I was terribly privileged. And I also thought I ought to see real suffering. I'm feeling very sorry for myself and made a half-hearted attempt to do away with myself. So I thought, I've got to go and work in a hospital. Slightly crazy. Yeah. And by a weird chance, father of a girlfriend of a friend of mine was a general surgeon in Ashington, a mining town north of Newcastle. And the NHS was a very different place in those days. So Jane, my friend of mine, asked her father, thought, Dad, could this unhappy young Oxford undergraduate come and work in the hospital? So he said, sure. So I spent 6 months working as a porter and anaesthetic nurse, totally untrained, in Ashington General Hospital, which no longer exists. And I loved the Northeast. I liked it very much. I liked the Geordies. And while there, I was writing lots of very second-rate Sylvia Plath style poetry and realized, I'm happy to say I destroyed it all. And I decided I wanted to have a middle-class career after all. I kind of rejected it, to my poor parents' horror. And I want to be a surgeon. I want to be a surgeon. And very, very fortunately, my Oxford college said you can come back, because I reckoned I wouldn't get into medical school if I flunked my first degree. I assumed I'd have to go to a so-called tech and do science A-levels. So I went back to Oxford, worked madly hard, took my degree in effect on the basis of 1 year's work. And on the basis of that, went to the last medical school, I think in the country, where we did a first MB course, a crash course in A-level science, because I had no science in my expensive private education at all. Well, I think I did science O-level in physics and chemistry, but I've forgotten it all. And then I liked being a medical student. I was a bit older than everybody else, but that didn't particularly matter. But when I became a houseman, as F1s and F2s are called then, I was actually rather disappointed, and I didn't want to be a physician. I started working as a general surgeon, but general surgery in those days was big incisions and smelly bodily fluids. And I always liked operating. That wasn't the problem, but it didn't quite suit me. And then purely by chance, I saw a brain aneurysm operation when I was working as an ICU SHO. And I'd never seen the brain surgery as a student, although bizarrely, and not coincidentally, my son had had a brain tumor at the age of 3 months. And he almost died, but he didn't. It was a very difficult time. But I don't know if it was my son's illness as much as just I found the idea of brain surgery, and particularly aneurysm surgery, irresistible. But not for good reasons. It was the risk, the drama, the glamour, you know. And my second wife is an anthropologist and says, Henry, you're a typical alpha male silverback gorilla, you know. And I was also young, and I was the youngest of 4, and always drawing attention to myself. And I made myself very unpopular, I think, on occasion with my siblings. I was quite difficult and throwing tantrums and very driven. And I've been very driven all my life. But when I saw an aneurysm operation, I knew exactly what I wanted to do. And I've never looked back. I don't miss the operating now, although I was totally addicted to it. But I was very, very lucky. And it really was, you know, the old Mark Twain's saying that if you find work you love, you never really have to work again. And although it was terrible at times, it's a very bipolar profession because there are so many bad results in brain surgery, because the brain doesn't heal in the way other tissues do, because it's so fragile. The actual operating is no more difficult than any other sort of operating. But the decision-making, the living with the awful morbidity is very difficult, and it's easy to be corrupted by that, because you end up seeing so many patients who become, dare I say it, almost subhuman because of severe brain damage, particularly if it affects the frontal lobes, and they have weird, unattractive personalities. So it's, the moral challenges are enormous, but it's incredibly interesting, as well as, in a sense, very fulfilling. I always loved patient care. It wasn't just the technical side. I did genuinely love relating to patients. And that's one thing, in a way, I do miss.
And do you think that being a sort of self-promoting silverback gorilla of your family, was that the perfect kind of character type to be a neurosurgeon?
I don't know. I know loads of neurosurgeons all over the world, and there are lots of different personality types. So I can't generalize. But I think you do have to find risk attractive. And I think most surgeons have to find risk attractive. I mean, most doctors don't want to be surgeons, and most surgeons don't want to be neurosurgeons. But you have to have that attraction for risk. And I used to think I became a neurosurgeon to show off in my usual self-denigratory way. But I watched that amazing movie, Free Solo, about this great Asperger's guy who climbs El Capitan.
With no equipment, no ropes,
And I'm not a mountaineer, and I haven't got Asperger's. But you live very intensely when you're operating. And that reminded me when you and I were under cruise missile attack in Kiev last October. I find it very stimulating. I was slightly embarrassed to say that, because I don't want to be a war junkie. But I mean, I can understand surgeons who become war junkies in a way.
Yes. Well, let me ask you a little bit more about that, because that's very interesting. You've just described 3 different types of life and death situations where the stakes couldn't really be higher. Scaling a sheer rock cliff with no protection or ropes whatsoever, cowering in a bomb shelter in Kyiv as missiles attack the city, and taking your hands and your scalpel to a patient's opened skull and brain, life and death for them. You're obviously attracted to the kind of stakes that might have many people running a mile in the opposite direction.
I think I can only think it's innate somehow. And watching that Free Solo movie, I haven't got Asperger's, but I don't think I've got a low resting pulse. There's this fascinating work done on kids in Mauritius, a contained population, which showed children with a slow resting pulse heart rate at a much significantly higher risk of getting into trouble with the police as teenagers. And it's a suggestion we need you need more stimulation to get the sort of response we want. And I don't know, but I mean, I regard myself essentially as an anxious, cowardly sort of person. So whether it's because I'm trying to prove something to myself or not, I don't know. My mother once said of me to somebody else that Henry always makes things difficult for himself if there's a difficult way of doing things. So it's a slightly it's almost masochism. I don't know. It's like running away from Oxford. I don't fully understand it, to be honest. But it is finding risk attractive. And what I only came to understand as the years went by, particularly looking back on my career, but of course the risks were to me and to my family, and not just to my patients.
Yes.
The whole work, partly the work-life balancing.
Yes.
And yes, our patients want us to be devoted to them,
Yes.
but our family want us to be devoted to them as well.
Yes.
And that balance is difficult, and it's changed over the years. I still go into the hospital every so often to teach. You know, my colleagues mainly have working wives, they share the school run, totally different from 40 years when the wife stayed at home and the male surgeon was working, and I worked 1-in-1 for 2 years at one point. I'm afraid I loved it, but in retrospect, I think it was excessive.
I should mention, by the way, we're getting some really fantastic questions in the Q&A, so please keep those coming, and we'll make sure we've got a good 20 minutes at the end of this discussion where we can feed in people's questions.
But the other thing I should say, actually, is I've had psychotherapy twice, once after I went back to Oxford, and once when my first marriage was ending. And I find it very helpful. I think we're all better for a support of psychotherapy. Because of course, psychotherapy is about learning about yourself. It's not about some bloody psychotherapist telling you what to think. It's very, very helpful, I think. If you're in a very stressful job, neurosurgery is, I think it's a good thing.
To some extent, has that been your motivation for writing? It's a form of almost therapeutic reflection on your life.
Yeah, I've kept a diary all my life. I started keeping it at the age of 12, and that was a combination of morbid adolescent narcissism, but also just the love of writing. And I come from a very bookish family. And also I had a very, very good education where I was taught to write. Multiple choice question exams didn't exist. But the diary, I've been destroyed all the diary I kept as a teenager when I was a young man, because I was embarrassed by it. I regret that now, because it would be interesting to see what a prune I was when I was a teenager. I was a complete wallflower and nerd. You know, I was there at home writing poetry.
Nothing wrong with those things.
Well, no,
from one nerd to another.
In retrospect, it was a good thing. My friends were all like, you know, learning to kiss girls and going to petting parties. And like, I was there, I was thinking great thoughts. But I built up a great backlog of things I've been working on ever since. But when it really was in the years of the end of my first marriage, which was very stressful. My first wife basically wanted a divorce. She was right, but I find it very hard to accept. And my diary then became very explicitly, really, a sort of therapy, because it was deeply traumatic, very unpleasant. We both behaved very badly. But I don't speak myself, but I did try to record it somehow, because I felt I've got to set it down, not really for self-justification, I don't think, because I was never going to share it to anybody. Just, I'm going through a very, very intense period of my life. I need to write about it.
Yes.
And then that marriage ended. I then met my second wife, Kate, who's a very accomplished writer and anthropologist, and has written this best-selling book on Englishness. And she would ask me, what were you doing at work? And I said, I'd read bits of my diary, because by then I was writing in detail about my daily work. Never with the view to, I really had no plans on publishing it. I thought maybe when I'm dead, you know, my family might find it. But Kate said, oh no, you can write. So when I'm asked, why did you write your books? I say, because my wife told me to. And it actually, it's the honest truth. But sorry, you want to have quickly, I think she is a wonderful critic. Virtually everything I write, and I mean, I do book reviews and the like, I always show to her first. And she's often says, well, I'm not sure about that. And I get very cross, but then she's always right. So it's wonderful to have a fantastic editor at hand like that. So it's huge,
And
huge
your,
to her.
your first two books were about the practice of
Yeah.
surgery to some extent.
Yes.
But your third book, And Finally, is very, very different. It's written after you have retired from neurosurgery.
Yes.
Crucially, it talks about you yourself becoming a patient.
Yeah.
So could you just explain why it was important for you to explore that?
Well, my publishers are very keen I should write a third book, because they know even if you write 2 bestsellers, the third book, however bad it is going to make them money. So I like the idea of writing another book as well. But I wasn't quite sure what to do. And I started reading a lot about the brain. And then I started with this joke, well, I'll have my own brain scanned and then we can write about the brain from that point of view. But it really bit me in the arse because my brain looked very atrophic. There was lots of ischemic white matter damage. And you can't predict, looking at a brain scan, how well somebody's brain is working. But my brain looked aged. I mean, probably not significantly different from any other 70-year-old, but it still was actually quite shocking. I was really upset because I thought my brain was really jolly good. And I did wonder, when I was operating, and your job is very tense, and particularly difficult aneurysms, and I'm sure my blood pressure was sky high. You can't do a study on this, but I do wonder sometimes whether the white matter hyperintensities, of which there are quite a few, it reflects, a hypertensive life. I'm not hypertensive now, but I do actually take a calcium blocker, and I don't know if that's a placebo effect or not, but I'll stop worrying about my blood pressure. And then the pandemic came along, and that was very interesting. So I was writing about that. And then I got cancer, or at least I've been sitting on my severe prostatic symptoms for a very long time. And eventually I thought, I really got to do something about this. Very reluctant, I was very reluctant to cross over from being a doctor to being a patient. But being a doctor, of course, I've got friends, and it's a very nice urologist at my own hospital who had operated on me previously for a kidney stone. So I went to see him, and he said, well, your prostate feels a bit hard. And I said, I don't want a PSA. I mean, it was just amazing how I was hiding myself from the truth. And my colleague said, come on, you got to stop burying your head in the sand. And that's what I've been doing for a very long time. And I write about that.
That is, Henry.
Sorry?
Why were you in denial about your
I think it's partly because I was a coward and frightened, and partly as a doctor, I was very reluctant to become a patient, although I had been a patient for lesser things like retinal detachments and kidney stones. I think as well, it's like, I'm a man, and English men are not very good at admitting to prostate problems, so they say. It's probably a number of things. But what was interesting, my PSA was 130, which is not good. And at that point, it was very likely I already had metastatic widespread disease, which can be fairly asymptomatic. So I went through a period of 2 or 3 weeks, not thinking I might really have quite a short time left to live. And of course, you go on to Google, you go on the internet, and it's, we all do, but on the whole, it does more harm than good. You just read all these awful figures, and then you realize half of it's probably all wrong anyway. But I was absolutely terrified, which I found quite, in a sense, quite funny, because I've been dealing with death and dying and cancer for 40 years. So for me, just as of you, death and serious diagnoses, telling patients they had cancer was an everyday experience. But when it was my turn, I really was not ready for it at all. So I was absolutely terrified and very, very upset. And although the doctors looking after me weren't terribly informative, at that point, it wasn't clear what my situation was. It was all probabilities. But I also was amused by when I first met the oncologist. In effect, I said to him more or less, how long have I got, doc, or worse to that effect. Although I knew perfectly well, nobody knows, because it's all probabilities. As doctors, we deal in probabilities. As patients, we want certainties. I want to know what's going to happen to me. And of course, The honest answer is the doctor doesn't know, not until you're right at the end of your disease process. So on the one hand, I was profoundly terrified and, rather pathetic. And there were two thoughts secondary to that. Firstly, was I've had a fantastic life. I've been incredibly lucky. I've had a deeply fulfilling job. I can look back on my life and I really don't have any regret. Yes, I have lots of regrets and I made mistakes and this, that, and the other. But, I've been very lucky, and particularly compared to all my patients. And really, Marsh, you have no right to complain. The other thing which struck me, being a patient did not come as a surprise. I mean, one or two of the reviews of this book talk about sort of bewildering transition, and there was a sniffy review in the Lancet, but it was the only sniffy, rather a bit sniffy, saying, they published all these articles by doctors when they became ill. So, oh, I learnt so much. I'll never treat patients the same again. That wasn't the case with me, partly because of my son's brain tumor, partly because my wife Kate has severe Crohn's disease, and I nursed my mother in her final illness. I had no illusions what it was like being an NHS patient, and the impersonality and regimentation and humiliation and everything else. And Kate, my anthropological wife, had educated me very well in the realities of being a patient. But what did strike me again was just I was so unhappy. But all my patients, when I told them they had cancer and brain tumors, would have been going through a similar process. And I chose, I'm a neurosurgeon, not a psychotherapist. I really did wear pretty powerful blinkers, but I related to the patient in the hospital at that time, and I just didn't think very much, if at all, about what was going on once it left the room or once it left the hospital. And I think this is necessary. I think one needs that detachment. Always talk about doctors need to be more empathic. Well, the strict meaning of the word empathy is to actually feel what somebody else is feeling. You couldn't do a lot of medicine you couldn't do if you literally felt. But how you find the sympathy, the compassion, and balance that with the necessary detachment is very difficult. And I've no easy answer to that. All I do know is that there's no substitute for personal experience.
So this transition from doctor to patient obviously is a very stark one for you.
Yeah.
It's not just any old transition. You have found out that you have what may well be a
terminal illness. Yes.
So you go from someone who knows that in theory they're mortal to someone who now might have a sort of date, even if you don't know precisely when it is. It's coming a lot quicker than you would like. How did you adapt to that, Henry?
Well, intellectually, sardonically, I said, great, I won't get dementia, because my father died from dementia at the age of 96.
Yeah.
And I really have a horror of it. But also I worked as a psychogeriatric nursing assistant once for 4 or 5 months. So I have no illusions about what it can be like. And I really don't want my family to have to see me decline, as well as I'm a proud, independent individual. So, dying from cancer is not to be, we all got to die sooner or later. And one of the big problems in modern medicine and modern society is this substitution of long life for good life, and concentrating on medical care, keeping people living longer rather than concentrating on the quality of life. I was very struck when I spent 5 years working on one of the NICE technology committees. I'd sort of volunteered for it because they said they wanted a surgeon on a technology committee. I thought, great, it's going to be kit, tools, machines. In fact, it was all pharmacology. And the only exam I ever failed in my long and distinguished academic career was clinical pharmacology and therapeutics. But in fact, it was very interesting because I had to do sort of clinical effectiveness assessments, looking at all these randomized controlled trials, mainly for new cancer drugs, often the Me Too cancer drugs. And what struck me so powerfully, and this NICE was based entirely on randomized controlled trials, was how that even in the trials done in less dodgy countries, in Europe or America, the quality of life data was often incredibly patchy. It's really very hard to get a feel for what the side effects were to this latest chemotherapy drug, which the health economist would then use for quality analysis to weigh against the potential life gained. I mean, it's better than nothing. I'm a tremendous believer in NICE and the whole NICE process. But this quality of life issue in modern medicine is very difficult. And it's hard for me to think, well, actually, it's better to die from cancer than die from dementia. Yes, I might not. These are all probabilities.
Yes.
I might be another David Attenborough, you know.
Henry,
it's unlikely. That's the point.
Yeah. When you were given this diagnosis, out of everything, what were you most afraid of?
Oh, just blind panic, I think, when my life was coming to an end. Cancer, you know. I don't think I had any very formed at that point. But then reading about it, I treated hundreds of men with prostate cancer, which had spread to the spine, causing paralysis. So, you know, it's quite likely that I will end up doubly incontinent and paralyzed if it metastasizes to my spine ahead of soft tissue disease. But human nature being what it is, at the moment I'm in remission with a low PSA and off the horrible hormone therapy. I mean, statistically, the chances are the PSA is going to start going up at some point. But I'm finding it quite easy to not think about that at the moment. And I'm living in the present.
Yes.
Which is easier said than done, but it's easier for me because I'm reaching the end of my life anyway.
Yes.
And I think of my young patients. I specialized in dealing in these slowly growing low-grade gliomas, mainly in young patients who are all desperate to see their children reach adulthood, things like that. And now I've got 4 grandchildren, I'm totally besotted about them, but I know I'll never see them into adult life anyway. But there's always a big gap between your intellectual rationalizations and what you actually feel. My next PSA is in 2 months' time, and I'm sure I'm going to be pretty anxious before. I can't help that. I wish I didn't. I wish I could just shrug it off, but I won't be able to, despite all my rationalizations.
A number of people are keen to ask you the same question, which is around the topic of assisted dying.
Yes.
And whether or not your own diagnosis has changed your views on assisted dying, and if so, how?
Hasn't changed them at all. I always felt there was a strong case for it. What has changed is that there's so many countries where it is legal now, it's becoming an area of evidence rather than expert opinion and hypothetical arguments. And all medical progress ultimately is based on evidence. We learn as medical students of the categories of evidence, starting with randomized controlled trials, with expert opinion at the bottom. And until recently, on the whole, the arguments for and against assisted dying were largely category 4 expert opinion. And that is changing now. There are lots of ways assisted dying can be carried out. It can be legislated for or against. Canada ran into trouble over assisted dying for psychological illness, psychiatric illness. My own view is it's such a difficult area. Probably the litigation should be designed so that you can't get assisted dying for a psychiatric diagnosis, which you can do in countries like Belgium and Holland. It doesn't seem to have led to great problems, but it's such a difficult issue.
How would you like to see the law changed in the UK?
My own view is I'd like to see it on the grounds of intractable suffering rather than the 6-month prognosis, but subject to strict safeguards. And in Canada, for instance, if you ask for assisted dying on the grounds of intractable suffering, motor neuron disease, whatever, you have to have a delay of at least 90 days. Palliative care is mandated. You have to apply all over again. It's not suicide on request. And yes, maybe there are going to be a few people who they die earlier than would otherwise have been the case. But all medicine is about a utilitarian balancing of cost against benefit. A very good friend of my wife's says now needs a heart transplant as a result of the COVID vaccination. But we know that the risks are really serious. And gave us cortical vein thrombosis with the AstraZeneca vaccine. So all medicine is a question of balancing costs against benefits.
Yeah.
And I don't believe that there's something called sanctity of life, which means it's an absolute no-no. Because in modern medicine, and particularly in something like neurosurgery and intensive care, you're having to make sort of life and death decisions all the time. You're not saying we can let nature take its course, because modern medicine has completely upturned it. Anyway, everything we do is part of nature in the first place.
So I'm going to carry on with the questions because they're so good. And this one is from John, who asks, so Henry, would you recommend today to the young Henry Marsh that he should join the NHS in today's environment?
Yes, I would, because I think things will get better. They have to get better because they're so bad at the moment. Being a doctor is an incredibly rewarding job. In many ways, it's more difficult now than it was 40 years ago, but there were, well, 40 years ago, the problem was people like me had no life outside medicine, which suited me, but not my family. I think being a doctor is wonderful, but I fully accept it's incredibly difficult. I was just lecturing American neurosurgeons earlier today, and they were talking about this awful loss of autonomy. And there's an overwhelming burden of paperwork and managerialism, which is it's happening in all healthcare systems all over the world. And it reflects the fact that healthcare is so expensive, so governments are trying to control it. And also the old adage, once you appoint a bureaucrat, the first thing the bureaucrat does is appoint two other bureaucrats, They have to justify their existence of endless paperwork. 30 years ago, I could bring Ukrainian colleagues over to my hospital in London, no questions asked. They could scrub up with me, they could assist me. I was trusted. I wasn't going to let them do it. I wasn't going to let them do my patients any harm. Now it's almost impossible. And the amount of paperwork and regulation is grotesque. But that's the nature of bureaucracy. We need it, but there's too much of it.
There are
loss of autonomy, the loss of trust in doctors is very depressing.
Yes, there are lots of questions about the future of the NHS and worries about that future. So this one from Karen Bolton asks and this is, I guess, in addition to the autonomy issue, what changes would you like to see in the NHS, and realistically, what changes would significantly improve NHS services?
Well, I mean, it's a slightly simplistic view. People say, I think it needs more money. And a lot of the crap going on is sort of squeezing blood out of a stone. I mean, the analogy I use, I'm just working on book review about various books about the NHS. And I lived through all these endless reorganizations. It really is like a game of musical chairs, where what's happening is there are more and more children running around the chairs, which is older people with complex comorbidities. And we're not really increasing the number of chairs they can sit on. And all the government does is change the music.
Yes.
And
I am one of those children, and it's very unpleasant.
Yeah. and it's, there's no question of the fact, and there's work from the King's Fund, from the from the Health Foundation, the NHS is underfunded relative to European countries which we would regard as our peers. Of course, come Brexit, our peers are soon going to be Slovakia and Romania and places like that, as the economy tanks. But I think there have been too many reorganizations. None of them have been very effective. They've just led to more chaos. I don't think there's any evidence that there's more management in the NHS than in other healthcare systems.
Yes,
and the cost of the management is a very small part of the total cost. It's a simple fact that there are more and more old people in the population, and there is more and more expensive medical technology with which we can treat them. Whether, I don't think assisted dying would help at all. More patient involvement maybe would. I was just reading this book by Phil Whitaker, who's a GP, saying, when you actually sit down with patients and say, well, in terms of statins, if you have 100 people, only 3 of them will actually benefit from being on statins. The question of side effects is arguable. And he says, if you actually discuss that with patients in those terms, quite a lot of people say, well, actually, I won't bother. And yet in one study, only 20% of people, 8 million people now on statins in this country. And in one study, only 20% had any information or explanation about what it was all about. And it is a big problem. Polypharmacy driven by big pharma, all that business. But that would be reduced by good doctoring, not by more management and more quality outcome frameworks.
Henry, I just want to mention something because someone has just commented on your mention of Slovakia and Romania and is concerned that that was derogatory.
No, no.
I didn't think you meant it.
No, in the sense of average incomes. The way things are going, average income in this country is declining in real terms.
Yeah.
And our peer groups will soon be sort of Eastern European countries rather than Scandinavia, France, and Germany.
So not in.
I was in Romania last week. I love to play.
Yeah.
I've been going to Ukraine for 30 years. No, it's to do with average incomes.
Absolutely. Okay. I just wanted to clarify.
Right. No, sure.
I hope that has clarified it.
Yeah.
There are some really interesting questions about your confrontation with your mortality, with your diagnosis. And this one from Keith Bucknell, he asks, would you have preferred to face your illness without all your medical experience?
No. I feel more, well, it's hard to know. If I was a naive, trusting old man, maybe I'd swallow it. Being the person I am, I'd much rather be in control and know what I'm up against. It took me quite a while to plow my way through all the professional literature. And at the end of the day, it doesn't matter because what's going to happen is going to happen. I've had the correct, appropriate treatment. And just as no doctor knows how long I'm going to live, I don't know. I mean, I am entering the final chapter of my life anyway, hence the title of the book, and finally. So by my age, it's really important to get away from, I need to live a bit longer. How much longer will I live? You need to count your blessings and decide what I want to do. And I'm lucky, but my family are well, and I have a good relationship with them, despite being an absentee father. And I've got plenty of medical work I can do in the way of lectures and work abroad. So I'm very fortunate, and it's a waste of time to try to understand what will happen. But that's being a doctor helps me understand that.
What about a very different situation when it's somebody much younger who's facing this? What is your advice to a young person who's having to confront the fact that they have a terminal illness, or indeed their family, maybe their parents, who are consumed with grief about that fact?
I can only guess, because I wasn't, although I had to break bad news and would see patients over quite long periods of time, I was never actually actively involved in all the psychological background to this. What I told patients, and I hope was correct, I said, the most important thing when facing an illness like yours is, first of all, knowing you're getting the best treatment possible. I'd say, by all means, go to Google or whatever, but I promise you, if you went to America and spent millions of pounds, it really wouldn't make any difference. Very difficult when I've been working in countries like Ukraine, where it would make a difference to go and spend a lot of money going abroad. Although that's, well, the war now has changed things, but that was improving. But on the whole, with my area of expertise, I could be quite certain I could tell patients, you are not, what I'm doing, I'm not the best, but I'm sure it's as good as anything you could get. Yes. So that's the first point. And the second point is to have a close, loving family. But that was the most I could say. And from then on, it's each individual, has their own struggle. One of the biggest, well, there are many problems about being a doctor. I think one of the biggest is you never know, or scarcely ever know, how well you talk and communicate, because patients never dare to tell you. So how can you get good at doing something?
Yes.
Yes, listen to your heart and all that. And hopefully with time, you learn slowly, but it's really difficult. Everything else in life, you get rehearsal, criticism, commentary, but these intense conversations with patients and their families. They didn't ring me up next day and say, Mr. Marsh, you told me I was going to die really very nicely, or Mr. Marsh, you were awful. On occasion you get criticisms, but you rarely get compliments, because rightly people take it for granted the doctor will speak well. And if you don't get to hear about it. I can think of one or two occasions where I really made a mess of it, and it still really upsets me that I could do something so badly.
A different question here, if this is an anonymous question, which do you believe there is anything after death, or do you cease to exist?
Yeah, we do. We live on in the memories of other people. We live on in our good works. We can't take our possessions and our expensive cars and holidays to the grave with us. The problem is, in neurosurgery, you see people with damage to the front of the brain, and this changes their personality profoundly, usually almost always for the worse. They become dull, selfish, disinhibited. Anecdotally, there's that famous Texas shooting when a guy climbed up the tower and killed all his own family and then started shooting people. And he wrote in his diary, something's wrong with me. You must do a post-mortem. And the post-mortem showed a malignant tumor growing in his amygdala. And we would say he's not responsible. Sorry? Yeah, it's extraordinary, isn't it?
No, I didn't know that.
Yeah. And it almost certainly caused this behavioral problem, because the amygdala is where fear and anger and everything else originates from. So we'd all accept in principle that if you have brain damage, your sort of moral agency is reduced. It's a big problem for criminal jurisprudence where you draw the line. But it's very hard to believe that as our brains decay and rot, that somehow something survives beyond that. But of course, what's so interesting about this, and I allude to this in my third book, is we just don't know how conscious experience arises from physical matter. And it does, there's no doubt about that. The brain must surely obey the laws of physics, unless you're a complete mystic. But the laws of physics tell us absolutely nothing about how conscious experience arises. Those are clever philosophers who said it's all a pseudo problem. There's something deeply mysterious which we just don't understand, and that's wonderful.
Yeah. Now, here's a philosophical question, perhaps. This is from Robert Blakey. So he asks, do you think grief facilitates precise work like neurosurgery or writing, for example? He wonders about whether in grief, the amount of experience of that felt existence of death somehow makes way for precision. So you have a cognitive consequence of an intense feeling in grief.
I have had very minimal personal experience of grief. When my mother died at the age of 82, she had a very good death, in inverted commas, at home, looked after by myself and one of my sisters, who's a nurse, and it took about 3 weeks. And I didn't grieve at all, actually. And I talked to her every day. I miss her greatly. In terms of terrible problems at work, when patients died or suffered terrible brain damage, either through a sin of omission or commission on my part, I didn't experience grief. I just felt incredible anxiety, guilt, and fear, which I think is very different from grief. I hadn't lost anything. But how you cope with bad results in medicine, and we all do. Psychiatrists have to worry about a patient committing suicide. I don't know any psychiatrists who haven't had that problem. GPs miss a diagnosis. Surgeons make surgical mistakes, misinfections, things like that. How you deal with that is not grief. It's fear, anxiety, and shame and guilt, and shame is one of the most intense human experiences. I think when I had my first bad results as a consultant, I felt quite sick for weeks afterwards, but you had to go on working. And then as the years went by, I had fewer bad results, not surprisingly. I still felt terrible, but usually only for a few days. You kind of get used to it. The problem is not to get too used to it. I tell my trainees, look, if they're upset about it, I say, it's good you're upset. You know, if you weren't upset, you wouldn't be a good doctor. So I think what's really special about being a doctor is failure, because we all fail to a greater or lesser extent. And maybe not in palliative care to quite the same degree, because it's rather different. But learning from failure, coping with failure, being open about it, teaching your trainees is what's really rather unique to medicine. I can't think of any other profession where failure, maybe the army, you know, sending people, soldiers to their death, is hugely important, and is what my books are about, really, I suppose.
So do you think perhaps something that is missing from medical school currently, which is all about how to fix and treat and help the failing human body and mind, is an education in how to fail?
Well, I think, yes. I mean, I do quite a lot of medical student lectures and I talk about that, but I think it's even more important once you become a doctor. And I don't know if the Royal Colleges have failure programs, but because it's when you become a doctor, then suddenly there's a glass wall between you and patients. Patients will no longer tell you what they really think or feel, not very much. And you're now the doctor, and all the mechanisms of self-deceit and, you know, self-competence you have to have come into play, and there's ego protection, which, you know, is responsible for a lot of trouble, a lot of interpersonal conflict, particularly in surgeons as well. Always defensive. One of my lecture slides for the surgical egos in Snow White and the Seven Dwarfs of the evil stepmother, and then mirror, mirror on the wall, who is the fairest of them all? And I speak for myself, I say most surgeons, we all have this sort of inferiority, superiority, anxiety. And this is one of the reasons why quite often surgeons fall out terribly, and we all know surgical departments where they all hate each other. And you can divorce your spouse, but you can't divorce your colleagues.
Change of direction now. Here is a question from someone who says, I'm interested as a healthcare professional, so in this case a nurse lecturer, who has previously worked in Ukraine, about Henry's involvement with the country, particularly since last year's invasion and the terrible crimes that have been committed by Russia.
Well, I've been going to Ukraine for 31 years. It was as a neurosurgeon. It's a long, complicated story, going back to my studying Soviet politics 50 years ago. Yes, 50 years ago, gosh. Neurosurgery is a fairly trivial part of battlefield surgery. Is not trivial to the extent that 25% of mortality is from head injuries. But, you know, you don't do life-saving, there's very little role for life-saving emergency neurosurgery in the battlefield. And that's all about blood loss and amputations and major organ damage and blast injuries and all these ghastly injuries you get with modern munitions. So that's not my involvement. I've been back 3 times since the war started, once, of course, with you. And it really is, well, it's partly I need to. I find it very difficult leading my comfortable, affluent life in London, knowing what's going on. But that narcissistic reason aside, I go because I really go to see my friends and reassure them there's still a civilized outside world. It's weird as you cross the Polish-Ukrainian border, and you're suddenly in a war zone, even though there aren't bombs falling on you immediately. It's a very strange feeling. And I do know, particularly my last visit, my friends were just so pleased to see me. You know, partly because I represent the hope for a better future, because what the war is all about is a democratic, free, economically successful Ukraine. It's a hard job to achieve, but I think they will. Is an existential threat to Putin, who is a kleptocratic autocrat. And a lot of people in Russia would like Russia to become like Ukraine. And that's what the war's about. All the stuff about history and ethnicity and all that's all window dressing. But the fact that a modern progressive European Ukraine is such a threat. And I had a meeting with the governor of the Lviv region a couple of weeks ago, and he was saying, we have lots of people visiting Ukraine nowadays, but you're unusual. You've been coming here for 30 years. And that means a lot to them. So I think the country is a young country, potentially with a great future. And that's why I've been going there. I never thought there'd be a war. I knew it was an important country on the borderland between Russian despotism and European relative freedoms.
Yes. Henry, we have to finish in 2 minutes. So I want to ask you just a simple question. Based on the decades that you have held other people's lives, brains in your hands, and now your more recent experience of confronting your own mortality, being given this diagnosis of cancer, what would you say to everybody listening? What for you is the thing that makes life worth living, Henry Marsh?
Well, makes life worth, well, ultimately it's your family and close friends, is biological. But as a sort of riff on that, my advice to all medics or would-be medics, and to myself, my past self, is ask for help. And secondly, you're never going to have good colleagues if you're not a good colleague yourself. It may not work, you may still have shits for colleagues, but it starts with yourself. And it's a charity begins at home. And I wish somebody had banged that into my head a bit more when I was younger.
Wonderful. Henry, thank you so much for this evening. Absolutely fascinating discussion. Thank you for being so honest. Thank you, everybody, for providing us with these brilliant questions. We've covered a lot of them, sadly, not all, but really wonderful conversation. Thank you, Henry, and good night, everybody.
Good night, everybody. I enjoyed talking to you. I hope you like listening. Bye-bye.
Bye-bye.